and thank you for coming again, because of course we had a session in February as well when you came, but quite a lot's happened since. And we're particularly interested today in the new NICE guidelines, and we're just wondering if we could explore that a bit with you. It's of course on the management of urinary incontinence and pelvic organ prolapse in women, and it's generated an awful lot of interest among the patient groups, and it was on the Victoria Derbyshire show, and that sort of caused quite a lot of problems. We put out a statement which we thought was very clear, and it was used quite a lot, and we weren't taking sides or anything. It was just saying where we were at the moment on the review. So we're just wondering if you've had any feedback from your members, and whether there's anything that you can help us with it in the views that your members might have, or indeed you personally might have, on the new NICE guidelines.
So our main issue is our members are confused, because we use the NICE guidelines to practice medicine, and we are told within the NICE guideline, and we're medico-legally held to apply the NICE guidelines as well often. So our members are saying there's a new NICE guideline out, and it says there are a number of different treatment options for patients, but we're not allowed to use, for instance, retropubic meshes. So how does that stack up? How does that work? Because we should be able to use it if we've got a body of evidence which suggests that there are different treatment options available. To withhold those options is not scientifically or in any way appropriate. So we've got the NHS England, who commissions and runs itself basically on NICE guidelines, giving treatment options, but at the moment we're not allowed to use them. So we've had a lot of queries from our membership saying we understand, the review is going on, but we're now being told by NICE that we can use different treatment options. Why can't we? Or can we? Or should we? Or when can we?
And what's been your response when they've asked you those questions?
Well, there's a letter from NHS England which has come out quite clearly saying that the pause is still in place. So that's what we tell our membership, and we say we're under negotiation and seeing what's going to happen from this point forward. Obviously, we've had the other issues. We've had the end of March was the point where we were hoping to have some decisions, and we've had patients waiting for a year and or more, or been lost within the system, or not able to have surgery. So there's a growing feeling from our patients that why is there another delay when the NICE guideline is saying that we should be able to have the treatments which we've chosen to have, and we've been explained to have, and we've had a good decision-making process, and why can't we self-determine our treatments if they're under the NICE guideline? So we've fed that back to our members, but it's an argument which doesn't square.
It's interesting also because, of course, the NICE guidelines are very clear in their research recommendation, because they've accepted that there's very limited evidence as to the long-term adverse outcomes for treating women with mesh. And actually they say that the final outcomes long-term are actually unknown. So there is a confusion, I suspect, all round. So having produced the guidelines, they are themselves admitting that there is a research evidence gap here, because they do not know the long-term outcomes for women.
That depends on the way that NICE looks at research. So they tend to look at randomised controlled trials and big meta-analyses, so they won't take into account say a case series of 18 years of TVTs, for instance, and look at the complications from that. So they have a different way of looking at the research.
They obviously feel they need to make a research recommendation, because that's what they've just done.
But the same criticism can be applied to everything, or bar very few exceptions in medicine, and especially in surgery, in that we don't have robust, randomised, quality data that you might have, say, for a drug trial, because A, they're exceedingly difficult to set up, B, on many occasions it's not possible to set up such a robust study, and C, there's not enough funding and the infrastructure to do that. And so I would argue that you could apply the same criticism for almost everything we do in surgery. And so I'm not surprised that they've recommended more research. No. And the sort of research that surgery can provide is often poor quality scientific data compared to robust, sort of multi-centre randomised drug trials that they may be used to. So I don't think holding out for more data, whilst we all agree that we want more data, we want to know more information, and we've been striving to set this up, I don't think holding out for that's going to be the answer either.
And of course, it's the meeting you're going on to next, to be able to capture the data that probably is needed to be able to help assess this.
But then we've tried to get funding to capture those data, and everyone wants the answer, but nobody's willing to support it or pay for it, and it comes down to cash.
So you will be, both of you, going to the meeting this afternoon with NHS Digital and all these other bodies. Sarah Chandler's also going, but obviously he'll be going as an observer, and he isn't part of the group, as it were. He's just there to observe. But I'm just going back to what is now, what has been produced by NICE. What are you as a society and you with your members? What are you going to do about this? Are you going to try and clarify it with NICE? Is there any action you're going to take?
So when the NICE guideline comes out, it comes out in a provisional form, and at that stage we send a mail shot out to our members and say...
Sorry, can you say what?
Our members get a mail shot when the provisional NICE guideline came back, and they feed back to us their concerns about the NICE guideline. We then feed them back to NICE, and they have a meeting where they take into account all of the different opinions from interested groups. Then the final NICE guideline is published, and it won't change now for 5 years. So that is how we practice medicine or urogynaecology for the next 5 years. And there's very little flexibility or interpretation within that.
But all along, all of the NICE guidelines have been exactly what the different societies have been recommending, and they hinge around adequate maximising non-surgical treatment, adequate information and open information about the options available and the risks involved, and accurate and hopefully complete data recording for the results of the treatment. And actually each of the societies, or all three of us, one thing we do agree on is that we all agree with the same things. Those are good standard basic treatments, so there won't be major disagreement with the NICE guidelines.
Yeah.
But we can't then say, oh right, we're going to start doing it, because you're still under the pause. Okay, for the bowel side of things, we're under high vigilance still, and so in a way it's business as usual. Now don't misconstrue what I say as business as usual as glib disregard. That means continued high vigilance under the scrutiny, applying all of the criteria that I've just mentioned, which we'd set up prior to this process anyway. The only advantage is where it is under such scrutiny, it does focus the clinician's mind to make sure that they are adhering to all of the different criteria, which is a good thing, because it hopefully hones down those clinicians doing this sort of work.
I think many of our colleagues sort of looked at the final report, which was different from the initial one. So initially TVT was included as one of the three options, and then that was altered to the final report with some other attributations to that. But people will look at that and will say we are all about offering patient choice and informed consent with good audit and follow-up, and that's all that we would want for us as patients or for our practice. So it doesn't really do anything other than reaffirm those desires from the clinicians.
So if and when the pause is lifted, what level of mesh surgery for SUI and products would you expect to see?
I would expect to see that the patient will go through a decision-making process where they're given all of the options, having exhausted conservative treatments, and then the patient will decide for themselves what suits them for their lifestyle and their circumstances. And for some people, there will be one of 3 or 4 different options that they may choose. It's not for us to tell the patients what they want. It's for them to tell us what they need.
But that's talking about the differences between the different options. What about the actual level of surgery per se? Because there has been an argument, hasn't there, that since the introduction of mesh, in fact many more people have been treated certainly for SUI. That might otherwise have been done. So do you think that there will be some sort of reduction generally in the level? Would you expect to see that? And can you think where we might end up as a sort of natural rate of surgery out another part?
Yeah, well, there's been a complete fall off a cliff, obviously, since the 10th of July. The rates were generally reducing from about 2014. I think probably what we were doing is we were getting rid of a backlog of a lot of severely affected patients with devastating stress incontinence who were treated and cured. And some of those patients now are out of the system. So certainly when I started doing TBTs, we'd see patients who didn't come forward for 15 years because they couldn't access the services. And then as the time went on through 2010 and 2014, they would come after 2 or 3 years, but not after 10 or 15. So there's a natural hump of patients who are have now gone through the system. But a lot of people have been frightened off, so we are at a much lower level. We're in prolapse, for instance, which is largely not mesh, is also fallen off a cliff as well in terms of activity.
I think it's focused the mind, not just for clinicians, but for patients as well. It is human nature for a large number of patients who want a quick fix. They want it sorted out. You're the doctor, make me better, without necessary investment in their own treatment or conservative measures, so pelvic floor exercises, retraining, other techniques. And I think it's good because it focuses the mind in that whilst we're at pains to explain to every patient that surgery is not without risks and it's all a balance, actually they now know that yes, there are risks to any operation, and so that will engage them in maximising non-surgical treatment.
Yeah, when we go through the patient decision aid, for instance, these days, we'll have a proportion of patients who decide they don't want anything done at all, and they'll choose not to have any surgery. And for them, they'll say, well, it's not a big problem. I would prefer to put up with this and undergo the risks of surgery. But for others, it'll be different choices, and people will want the biggest, nastiest operation that we do because they want the maximum chance of a cure. So there's a variation of options chosen.
Some of the patients we've talked to have actually been doing their exercises as they've been told to do, and they have found it's made a bit of a difference, but they have gone to see the GP and then to the surgeon, and the surgeon said, oh, you don't really want to bother with those exercises, we've got the answer to you. And they have then had mesh inserted, and we've seen the results on that individual. Now, I appreciate this is not evidence in terms of statistical or anything like that, but obviously we've been listening very closely to what patients have had to say to us. And what I'm really asking you is that clearly some of the patients who we meet have had mesh inserted quite a while ago, and I am asking you whether you think the practice has really changed in terms of consent and the attitude that some surgeons actually exude when they interview patients. Do you think really today that consent is treated quite differently than, say, 5 years ago?
It's hugely different. It's a complete world set away from how it was 5 years ago. So I look at my consents from the late, from 2005 to 2010, and we didn't really understand all of the risks and consequences of some of the surgery. And they were short, and patients would demand surgery, and we would be willing to offer them surgery with fairly easy things like, I've done my pelvic floor exercise and it doesn't work for me, doctor. I've been away for a few weeks and they came back and it hadn't worked. So the whole consent process is a hugely different process now. It takes a good half an hour of our time and has altered our ability to practice continence surgery because we need so much extra time to consent patients properly, go through 4 individual sets of information, then go through a patient decision aid, send them away to think about it and bring them back. So yes, the whole process is hugely different.
The other thing that's changed as well, and I think you'd agree in your world, is the MDT working process, in that the individual surgeon and patient, just two people to making the decision, has now gone from pelvic floor decision making and treatment, in that they're part of an MDT process, and the decision for surgery, certainly in the colorectal world, is through an MDT process. And so it's not just one person deciding, it's, well, have they done this, have they done that? Let's hear from the people who are doing the pelvic floor exercise. Do you think they've done well enough? Well, could they have engaged more? And so you're less vulnerable to sort of quick decision making in that way, which I think is an important part, in addition to everything that Jonathan's just said, because it's exactly the same in the bowel world.
So if a patient feels they could have a bit more help in terms of the exercises and so on, do you ever refer them then to the physiotherapist that actually is expert in this particular part of the body?
It's mandatory
Yeah.
to refer everybody
It's
to
mandatory.
pelvic floor
You have to do it.
physiotherapy. In my practice, it's absolutely mandatory. We would not be able to offer patients surgery unless they have a documented evidence of receiving pelvic floor exercises taught by a specialist.
Right, okay. So going back to the NICE guidelines and the pause, if the pause is lifted, and you will know the 5 safety measures that we actually have to introduce before the pause is lifted, the second line treatment after conservative treatment has failed, if that's happened, and if the third line option after conservative treatment followed by non-mesh surgery has also failed, does the previous non-mesh surgery impact on the risk-benefit profile of using the mesh?
So say that one again. So they've had previous surgery, non-mesh surgery.
Yeah.
Oh, I think we're talking if they've had a periurethral injection, for instance, then if we offered them a TVT afterward, it's generally considered that that is an appropriate treatment option, and the previous periurethral injection is unlikely to affect the successes of mesh surgery. But there's a study in Manchester specifically looking at that at the moment.
But what if people have had something like an autologous sling?
You're going to get a lot of scarring, and then you're going to get difficulty doing anything after an autologous fascial sling. So putting a mesh in that situation, when the mechanism of action and so how it works is the same, might not be an obvious choice. But that would be, again, a decision for an MDT and patient involvement in that.
I guess the question is, does using something like an autologous sling become the sort of final surgical step, or is there then a third line?
You can always find a third line, so you could use a periurethral injection, for instance, after an autologous fascial sling. These are things for the future that we're going to learn, because the autologous fascial slings and copper suspension have been done in relatively few numbers over the last few years. So now we're doing them again in larger numbers, then we'll find what we need to do with the failures, but it'll be sort of easing our way forward as to work out what the next best step is. And you might ask 5 different surgeons and get 5 different answers as to what they would do for a failed autologous sling. When we looked at failed TVTs, for instance, we get a huge different variation in what we think should be done. And a study is going forward now looking at failure of continence surgery to try and determine the best treatment afterwards. So that's an NIHR study, I think, which is just open.
I think one of the key points of this, one of my concerns is that for totally valid concerns over the risks involved with a TVT mesh and synthetic mesh, what we don't want to do is get into the situation where we're not doing a very appropriately selected operation, and we're doing an alternate operation which has an equal risk component to it, but then that prejudices success of what was the proper operation in the first place.
Exactly.
That is
And
exactly the
so
issue.
we don't want to go, okay, maximum pelvic floor exercises, maximum conservative non-surgical treatment, we're all totally agreed with that. MDT process, consent process. What we don't want to do then is go to autologous injection or injections, which we know won't really work, but we're not allowed to do anything else, then autologous sling, which isn't as good as a TVT, we think, but it avoids using the mesh, but then you've burnt your bridge to do what would have been a really good operation, the TVT.
That's where we are.
Don't you agree? Exactly
where
right.
we are. So we're putting in autologous fascial slings because that's the only option that we have for patients who want a significant chance of being cured of their stress incontinence.
Which doesn't work as well, but it's also meant that when you come to do the TVT, which is the best operation, with problems and with risks, and we totally accept that, then actually you've increased your risk profile by already sullying the waters with an autologous sling.
So that's the negative aspect to any pause, is that patients are getting bigger operations with significant dangers and complications, and we'd forgotten those dangers and complications, and now we're remembering how it was 20 years ago when we used to do them. We haven't forgotten them, but we're now having to manage them on a day-to-day basis, whereas with TVT type operations we would have complications, but they would be less frequent.
Because of course that's what the patient groups have been saying, that actually the mesh procedure should be the third and final line, that actually you reach.
I think that's an error.
Done. And you're saying it's an error.
Certainly.
I'm saying it's for the patient to decide. Some of them are so frightened of mesh they would never want to mesh near them. And some will say, you know, I had a patient and she wants to get back to her job. She can't afford financially to have 2 or 3 months off work with a fascial sling, and so she's waiting for when the TVT option will be the one that she wants, and she's waiting until the pause is reversed.
So have you any sense of the numbers who are sitting on the offside, as it were, waiting for this watch to be lifted?
There's quite a lot. So different places are addressing those issues differently. We're not allowed to keep them on a waiting list, so they have to be taken off the waiting list because they're not allowed to be on for more than a year, otherwise the trusts get penalised for this. So we'll find that patients, we've been told to remove them basically, so they will be lost within a system probably.
Not being treated, just taken off.
Just taken off and not being treated, yeah.
So these are all people where conservative treatments have been exhausted?
Correct, and they want an operation, they've chosen to have a TVT or synthetic mesh, and they are unable to have it, so they can't be on the waiting list, so they have to go, they just come off and they usually discharge back to their GP, or they can go back to clinic follow-up. So different places are addressing what we can do. So quite a lot of people have just stopped and paused everybody until the 31st of March when we were hoping a decision would be made. Some people are offering injections for a lot of patients on the basis that it might help a bit, but it's not likely to compromise further surgery and may help a proportion of patients. And then some are having the bigger operations, the fascial slings instead. There's quite a lot of people on waiting or on lists somewhere which are choosing to defer surgery. There's a specific patient group. So if you're overweight, your BMI is say over 35. The operations such as cochlear suspension and fascial sling are technically really quite challenging. So your MDT is going to ask you significant questions if you've got patients with a high BMI wanting those operations. So for that group of patients, a TVT type operation would be something which would be technically possible, whereas the other ones aren't, and have a reasonable effect, whereas for periurethral it doesn't work for everybody. So we've got a specific group of patients who are, say, slightly raised BMI, who have no option at the moment.
But we've been told that losing weight in itself aids continence.
Part of the NICE guideline is you should advise all patients to lose weight. Those are challenging discussions with patients and challenging for patients to achieve that weight loss as well. Some CCGs have criteria as to what sort of BMI you can offer surgery for patients. So there are some guidelines for that.
Well, when a woman has had mesh implanted, do you do follow-ups? Do you call her back in a year's time, 2 years' time, 3 years' time?
We routinely follow everyone up for usually 3 months is the commonest data entry point for the BSUG database. Some people follow up for 6 months or a year. So most people will see a patient back initially. We haven't got the capacity really within the NHS to follow up everybody for a great deal of time, and we're dependent on the GP sending patients back, for instance, if they have complications. So if we think, say, 100,000 TVTs have been inserted, if they were coming back every year, that would be, several people's jobs in itself just to do follow-up with those patients. So we will have an initial assessment, and that can be where we fine-tune the treatment. For there may be drug therapy needed, or there may be other problems that we need to sort out. But most people don't have long-term follow-ups. I personally will follow patients up, so we have an 8 or 10-year follow-up point where we've sent patients information and brought them back up and seeing how many have pain and how many have problems. So individuals may be able to do that within a healthcare setup if they have done it themselves, but not as a routine.
And do they publish your age-10
Yep.
But
this is going to be
you have a registry, don't you?
We do.
And that presumably you do have a follow-up with that.
The follow-up is fairly ad hoc, though.
Sorry, the follow-up is?
Fairly ad hoc.
Oh, right.
And as I've said before, the registry is really a registry of operations and implants. And so we spend a long time, and this predates the explosion of the mesh concern, because we'd felt that it's something we wanted to keep a track of. And so we can tell you who's had which mesh and when and for which indication. To some extent we can talk about the results, but they're not robust enough to give us the data that we need for complication rates, success rates, failure rates, recurrence of prolapse, which is where the HQIP work is going to be quite crucial. And it also comes back to the longer term follow-up. Because if we had a NHS digital based data collection system, then that would do our preoperative, our post-operative data, and then there's no reason why patients couldn't automatically be approached again at 6 months, 1 year, 2 year, 5 year, 10 year to get those long-term data that we can't within the sort of clinical NHS. We don't have the luxury, unless we're told that there's a problem, of routinely following up those patients.
But you could do the follow-up through digital means.
Exactly, yeah. And that's what we would all want, is that an automated, you'd get an email said, you had an operation 2 years ago, can you spend 5 minutes just filling in these questionnaires that you've already done? And it can all be done, electronically.
We don't get good patient buy-in to those sort of initiatives, unfortunately. So we send everybody a self-addressed urinary symptom questionnaire at 6 months, and we get less than 40% of patients who will be bothered to fill out the questionnaire and send it back to us. So we've looked at how to follow patients up, and you have to get somebody to phone them. It's actually the only or the best way of getting anywhere near good follow-up. And certainly when we're looking at our 8-year data, a very enthusiastic registrar to phone, and we've got sort of 90+% follow-up. But other than that, you don't get patient follow-up.
Clearly, that's not tenable. But I would argue that actually we would have a negatively biased results because the people who've had problems or aren't quite right are more likely to let us know, and so the ones that can't be bothered to fill it in is that you've given them their life back to such an extent that they're too busy on the trampoline with their grandkids or going for a run to actually fill in the questionnaire, which is what we want.
We've looked at that, and actually we find the patients least likely to fill in the questionnaire are the ones who are cured and don't come back.
But if you know the number of people who've had the procedure, then you kind of know your percentages. So it in a sense it doesn't necessarily matter if the only people who report back are the people who've had problems, complications, because if you know your total database, you know what percentage they represent, and therefore what percentage is the silent minority or majority.
I totally agree with you, but that's not scientifically robust, and so we would just be criticised completely. So we can't assume that. But even though we all know that's probably likely to be true, probably likely isn't good enough. And that's our stumbling block, right?
In terms of mesh removals and salvage, are there, again, if you think about a situation where the pause is lifted, are there enough surgeons to be able to handle that at the moment?
It's an interesting question. The patients are tending to move towards some centres which are overwhelmed. There are some centres with long waits. So I will see a patient, I'll say, you can go to London to blah-de-blah, or I'll do your operation here for you. And a proportion of them will choose to go to London, and those centres are being overwhelmed. So I've got loads of space, and there's no problem with seeing patients with mesh complications. But that's not the same for some of the well-known centres.
Why is that, do you think? Why are the patients voting with their feet in that way?
I think patients buy into certain surgeons, to be honest, and if you have a profile on the internet which is positively received by patient groups, you're well recognised in that area, and you're understood just to be a caring, diligent doctor, then the patients will tend to vote with their feet.
There's a lot of evangelism as well. And one of my other concerns, and concern of many of us, is that whilst there's no doubt that meshes have caused problems, we have to be also very cognizant of the fact that we can do harm by our desires to combat the problems that the meshes have caused. And so we need to be equally as restrictive about who's doing the mesh complication work, and it needs to go through the same rigorous process of what's appropriate. Because at the moment, in the absence of a definite mesh-related problem or evidence thereof, be that clinically, or examination under anaesthetic, or imaging, there's no evidence that taking the mesh out is going to actually improve your pain, say. If you talk to all the major pain experts, you may just have the same amount of pain, but you won't have a mesh. I would argue, and many of us would argue, that actually that's not necessarily doing the patients any good, and you're much better off doing a holistic approach to actually improve their symptoms rather than just remove the mesh.
Can I stay with this on mesh removal? Women have told us that they've been offered a full removal, or full vaginal removal, but actually that's not what happens. And the question really for them is whether the surgeons know that when they go in, that they're not going to be able to remove it all, or they hope they're going to and actually come out with a partial, but are told that it's been removed. And they know, they still have the pain, they don't know whether they've actually still got it there or not. And this question about what is in fact feasible about a mesh removal, so if we're talking about the TBTs, if we're talking about how you take that out, are we quite clear that we're all talking in the same language?
No, because the language you use I don't understand. So when you say a full vaginal removal, that's impossible. So you have to take, if you wanted a full mesh removal, you would have to do a cut or a laparoscopic procedure to take the abdominal part out.
Right, so that's the point. I think what they're saying is, we think we're going in, we think we're going to get it fully removed. What actually happens is you take the sling bit out, but the arms are left in, and actually you couldn't do the full removal. And let's be quite clear that I've got this right. You can't do a full vaginal mesh removal without doing the groin incision too. Is that absolutely clear?
Okay, so there's a retropubic removal, and there's a retropubic and there's a transobturator tape.
Right,
so
let's stay with the retropubic.
The retropubic, you can remove the whole of the tape usually, but it will involve some sort of abdominal procedure to take out the abdominal aspect to it.
So let's be absolutely clear. If you're going to take out that transpubic one, if you're going to fully remove it, it can't be done unless you're also doing an abdominal incision somewhere. It's not just taking out the bit through the vagina. You can't.
I wouldn't be able to take the abdominal bit out through the vagina. It's usually stuck to the bones at the back, and you have to.
So for the women, they can be quite clear if they've been told that's not going to happen, they don't have the groin incision, the chances are it's not been taken out fully.
Okay, so the sort of situation here is I would discuss with the patient how much of a mesh she wanted to remove and how invasive we want it to be. So if she had pain suprapubically, then we'd be more likely to say, well, I think we need to take the upper aspect out. If she had pain vaginally, then we might just take the vaginal aspect out. So usually the surgeon would come to a discussion with the patient as to what her symptoms were and what the best approach to the mesh removal was. The more mesh you take out, the more likely to be incontinent again. So sometimes we just do purely abdominal excision of the mesh, sometimes purely vaginal, sometimes a combination, sometimes a bit at the back of the bone, sometimes just a bit superficial on the sheath. So there are various different ways of doing mesh removal, and not all suits one person.
but the women should not be misled to believe that they've had a full one when actually potentially they have.
Misleading patients is a propriety issue and should go to the GMC.
Completely that. Can I ask you this question? One of the women said, well, surely it's very simple. If there's any doubt about whether you've had it removed or not, if the implanting surgeon were to say, this is how much has been put in, 24 centimetres or whatever, and when it comes to be taken out, actually we've taken out 8. Would that be so difficult to record that automatically as part of the surgeon's notes?
We tend to now because patients ask for it. So they said the other week, show me all the mesh that you've removed. So we had to take a photo of the mesh that we've removed.
Do you record what you've put in so that there's a clear measure of how much has been put in?
We don't record. We never recorded what we put in.
Why?
And I don't feel it's necessarily valuable. You find one end of the mesh and you go and get it down until you get to the other end, and that's then the whole of the mesh.
But you can see if the women are saying, well, we don't know, how can we be sure? Wouldn't that be just a very simple way of dealing with that problem, because they know what was put in, they would have seen it, the surgeon would have told them, 24 centimetres went in.
No, it stretches as well, so
and
22 might go to 26. So
but it wouldn't go from 24
down to 18.
Down to 8.
No, they shrink.
They wouldn't go to
24 to 8.
No.
So 8 comes out, 24 went in, that's clearly you haven't taken it all out.
Yeah. I think these are not difficult decisions. They should be between the surgeon and the patient. What of mesh have you removed? And the patient and the surgeon should then be able to say, I removed the suburethral portion, I removed the retropubic. They will occasionally get the situation where you think you've got it all out and there's a few strands left. That can certainly happen, and then scanning and things may help you with that. But I don't think surgeons should not be specifically misleading patients about what's been done. You would go to the patient afterwards and you say, yeah, I've removed it. So the lady on Monday, I said, no, I've left your mesh in the retropubic space because it was too difficult to remove. But I've taken the suburethral portion out and I've taken the bit out here. And I had a discussion before with that patient as to whether that was acceptable to her.
So
I think there's a problem with communication because a
I
lot
think
of
you're
the
right.
patients actually believe they've had it all taken out, and then they find they haven't. And they are then very concerned because they thought that it had all been removed. And I also understand that mesh gravitates as well. It goes into other parts of the body. And so I imagine what you're trying to do is actually extremely difficult because you're not only taking out what was put in, but actually you don't know where else some of the mesh has gravitated to.
I don't really buy into some of the thought that it disseminates around the body or spreads. I think some of the non-heat treated earlier meshes, they could fragment a little bit, but the meshes don't move. Once they've been in a fortnight, they stay there, and I don't really think they go anywhere else around the body. But a little strand or a little bit here and there, you could miss that. I think you say communication is exactly the most important bit here, and I can only speak for myself when I say I hope I'm communicating well with my patients. Whether they necessarily remember what I told to the patient on Monday about how much mesh she'd had removed in 5 years' time, it is also the challenge.
I think one of the other questions we've had raised is that if you take out, say, the central portion of the sling, it is therefore in subsequent surgeries much more difficult to locate the other bits of it that were left. And I think that's what...
That's with transobturated meshes, certainly, it can be difficult to identify them full stop. So you may have to search around in all sorts of ways to try and find the mesh and then remove it in its entirety. Yes, it's not necessarily easy surgery.
Are you aware of any surgeons internationally who use different methods for mesh removal than we do in this country?
We've heard from the patients group. There's a chap in the States who's been very well regarded within those forums for mesh removal. The transobturator meshes removing the lateral arms is a big challenge, I must say. And we're learning those challenges now. So yes, it's something that's been new to us a few years ago to remove the lateral aspects to it, and there's different centres along that learning process.
And are there efforts to learn from colleagues internationally who seem to have been doing it for longer, or is that not happening?
Certainly, I think there's a challenge with the lateral aspect of TOTs, and Chris Harding sent a very useful video around about finding the lateral aspect of a TOT. I found that really interesting to watch, actually, and very informative.
I'm not sure sure what the opportunities are for importing that sort of learning to practice in this country. Is there a way that the societies think that they can do this?
We have international meetings, so we often will go abroad and talk to other surgeons at those things, and for instance there'll be video techniques where, you know, this is how I remove a mesh. Obviously you show your best version on the video rather than the one that's very difficult and challenging. But we'd already have international collaboration, and I think Scotland is also doing that at the moment from what I've heard.
You mentioned scans just now. Can I just ask about translational scans? As many of the patients have talked to us about translational scans as being the most effective way, as they understand it, of imaging mesh. And they've obviously also talked about the very sparse availability of translational scans on the NHS, and the fact that they have to resort to private scans, which are costly and apparently increasingly costly. What kind of imaging is optimal, and what should be available in the NHS?
So the person from America who we've just talked about doesn't believe in scanning at all and never uses it. So that's sort of one interesting thing. I've just written a paper with a group of international experts on the place of imaging for TBT type tapes, which will be published within the next hopefully a few months. Translational ultrasound scanning is best at imaging the suburethral portion, but it doesn't image any bit behind the bone. So to image that, you need an MRI type scanner. The experience of that is that there's not a lot of published experience. It's one of the areas that does need more research. For most clinicians, the use for scanning is if you can't find it and you need to know where it is. But if you've decided to remove a painful mesh, a scan may give you relatively little extra information over. If a patient has pain and you want to remove it, you need to remove it. If the scan says X, Y, or Z, it doesn't make any difference to your treatment plan. So the translational scans offer relatively little extra information. The MRI scans, you have to have special techniques and protocols which are not widely available, which we will publish for looking at the bits behind the bone. You can compare one side to the other because there's no good data about what they normally look like. So if you can see one's twisted or in the wrong place or close to a nerve, you may get information. But if you've decided you're going to remove it, you're going to remove it. And the extra information you get may not be a significant amount. There's less people doing translational scanning now, so some people are moving from the market. They're not offering it because they find that it's a difficult consultation when they do the scans with patients to give a fair and unbiased information. So you can say that the tape is there or not there, which can be useful. You can see sometimes when you're on secondary removals, that's very useful if you think someone's been left behind. But there's a reluctance for people to get into this area.
Why is that?
You may be the guinea pig in the middle between the clinician who's referred you for the scan and the patient. And the patient is obviously, or may well be anxious and may have a lot of buy-in to what this scan may find. And actually all you may say is, I can see your scan, your tape. You may not have, it may give you no extra information. So the patients may be putting a lot of weight on that scan, whereas actually as clinicians we don't put as much weight on it.
So is there something about communicating that message out? Because I mean, if what's happening is the NHS aren't providing it, private sector thinks, this is something we can move into, and the patients seem to want it, and they're charging what the market will bear, and quite a lot of money. Do we not owe some responsibility to the patients to say, hang on, we need to be telling them this message that it's not actually making a difference, or we need to be able to impart that?
Perhaps we're giving different messages. So I would, when a patient has come up and said to me, I need a scan and I'm going to go and pay for it, I will do the scan hopefully there and then in the clinic and say, there's your tape, and give them the information, so they don't necessarily go and pay for it. But if we're getting mixed messages, so some surgeons will send all their patients for a scan. So there's mixed messages going to the patients.
So the societies have a job here to try to make sure that message is consistent.
We need specialist centres for mesh removal where we can analyse the technology better and find the place of scanning. At the moment, we don't see a huge place for it, but we need to run that study where everybody gets a translational ultrasound scan and an MRI we go then to look at the clinical indications, and we try and work out whether that scan has been a beneficial effect or not. So rather than using the anecdote, we need more evidence.
Can I just ask something about implanting in relation to scanning? So am I right in thinking that when inserted, TVT or TOT is inserted blind, as it were? You're not using a camera or any imaging equipment?
The needle goes at the back of the bone in a I don't like the word blind fashion, if you know what I mean. It is yes, a blind method of inserting it, I suppose.
And is that
it's not guided? And that's the point.
It is guided, yeah. It's guided by anatomical landmarks. So we all insert them slightly differently, actually. So I insert them slightly laterally to my colleagues who insert them more medially. So we use anatomical landmarks to reduce the risk of damage to the bladder or the urethra or other things. And some people will move the urethra out of the way, and some people won't. So there are lots of different ways of doing it.
Is it unusual compared with other surgical procedures to do it? Let's use that word blind, advisedly.
No, not really. One of the commonest gynecological operations is putting a telescope into your tummy, and that's done blind. And 1 in 200 cases it goes into your bowel, and you end up with a bag on your tummy because of a major complication. Sometimes it's a bit less than that, but those are the broad statistics. So certainly within I think within many specialties, I would think that some blind procedures.
I think blind is the wrong term. Best analogy is you're getting up to use the toilet in your own house in the dark. Do you get up, turn on all the lights in the whole house, wake everybody up and have them guide you to the toilet? You don't. You know where your toilet is, you know the various obstacles you'll have to negotiate, and you'll find your way through experience and through knowledge and through knowing the pathway. A lot of surgery is experience and knowledge. You know all of the different landmarks. So you're not blindly going to the toilet and walking into the wardrobe or the wall. You go to the toilet well negotiated. Very rarely one of the children will have left their sort of toys halfway across and you may trip over. And so rarely in an operation you will find unexpected aberrations to your anatomy where you may have a problem. But the vast majority it's all fine.
But if you take something like TOT, you're operating very close to some major nerves and blood vessels.
That's the same for most of what we do.
So it's not particularly unusual in that sense, is what you're saying.
No.
For it to be unguided or blind, and for there to be very significant nerves, blood vessels, and other.
The NICE guideline is not recommending we use TOT as a surgical treatment. So we sort of should put that to one side, if you know what I mean. So when we stick, it's basically a big knitting needle, and there's some big blood vessels there. 1 in 400 cases, I will hit a blood vessel, and somebody will have a haematoma. 6% of patients will have hematomas up to 5 centimetres because there's some bleeding where you're passing it through behind the bone. But we all have got specific ways of how we thread the needle up. It's funny with the mesh operations, we're now opening up and we move everything around. So we move the bladder out the way. We still stick it through the bladder, unfortunately, so often. But blind is a coarse way of describing a highly skilled procedure.
It's very difficult because as a patient, a lot of these terms and a lot of the descriptions can be very alarming. Because you think, you what? And understandably so. But actually, I'm not a urogynaecologist, but I've worked very closely for many years with them and we work together. And actually, putting it through the bladder is not a disaster. What is a disaster is not realising you put it through the bladder and leaving it unrecognised. And so again, a lot of the bleeding is all contained, and so actually it isn't a major problem. It is an accepted percentage risk. And if it happened in 100% of the cases, then clearly the operation is not a good operation and we'd find other ways of doing it. But just because these problems happen doesn't mean to say it's a flaw of the operation or it makes the operation unsafe. I mean, I think you'd agree. And I think where problems occur is when there are problems and people do not recognise them or don't act upon having found them. And that's the crux of the matter.
Can I just ask you, all the time things are changing, and the NICE guidelines are an interesting example of that. But we know that in November 2019, this year, that the commissioning is going to be done by a specialist commissioning. And the current estimates, I understand, are that we will end up with 47 mesh removal centres around the country. There are currently, I believe, about 50 centres, I think, that you told us about inserting the mesh across the country. So just thinking about the framework for the future to access these 50 centres I'm talking about, do you think that through this specialised commissioning that they will actually reduce the number of mesh inserting centres?
So
do you think that will happen?
I'm a clinical advisor on that, on the specialist committee, specialist commissioning board. So some of those figures are just a little bit wrong. So they're looking at somewhere between 8 and 12 mesh removal centres. So there'll be regional mesh removal centres. So there may be sort of 2 or 3 in London, which will purely be looking at mesh removal and also mesh insertion for prolapse. So
that's quite a lot compared with what we have now.
Well, I think it would be appropriate. So the figures have been looked at to see the number of patients that are coming through, and that's sort of the numbers that have been recognised as needed. There is a bulge of these patients coming through at the moment, I think, with the anxiety and fear that's come across. So I think they're going to be very busy, those centres, to start with for mesh removal. There will then be 50, as you say, roughly 50 specially commissioned centres. And they would be the sort of centres that you would expect to provide surgery such as an autologous fascial sling and a cochlear suspension. The TVT before the pause would not be specially commissioned, so it would be performed within normal commissioning, so within the normal DGHs, as they used to be called, hospitals. Because, say, up to 10,000 of those procedures were performed a year, they wouldn't be specially commissioned, they'd be routine care. So if the levels fall below 2,000 procedures a year, then they become part of specialist commissioning. So I would have thought if we sort of restart where we were, that TVT type procedures wouldn't be specially commissioned. That doesn't mean to say there shouldn't be special governance and requirements so that we are sure that patients get full conservative therapy, they get the proper consent process, and all patients go on a database. So there will still be those requirements, I would hope, wherever the care actually takes place.
So you were saying there are 10,000 before the pause TVTs.
Yeah.
And are you expecting there still to be around that level?
It went to 14 to about 7,000, I think, before the pause. So it was already sort of falling down. We're seeing the periurethral injection treatments. You would expect those would have gone up massively within the pause. They've actually gone down by about half as well. So we think the general treatment for continence is probably going to be, a half of what it was before the pause started.
So I mean, if we're talking a half and we're talking increased anxiety and other options, you still don't think they'll fall below the 2,000?
That talks about 3,500 type level. I mean, if it does fall below the 2,000, then yes, it will be a specially commissioned surgical procedure, and then it will go to specialist centres. I wouldn't be too surprised if that didn't happen. Okay. But it's a problem then with the provision of service. So the specialist centre will have difficulty doing all of the fascial slings, cochlear suspensions, and TVTs. We're looking at networks to make sure these things work. So perhaps a specialist centre may do all the fascial slings, and then you can commission out to experienced surgeons who've been doing TVTs for 20 years, possibly to do those in a different centre. So there needs to be a hub and a spoke, and it needs to work for patients.
But the thing we don't want is just people to have a go.
I really believe I don't want people to just have a go. But I think that's gone.
The secret to that is the MDT working.
Yeah.
In that lends itself to a hub and spoke. Each hospital will not have an MDT process for pelvic floor problems. But there's no reason why they can't feed into an MDT, and then that's exactly where the hub can be where the MDT is based. They can do the super complex redo surgery, but then not sanctions the wrong word, support the decision making for more routine surgery where TVT will take the place. I think if it falls below 2,000, we're doing too few. So either you are just allowing a large number of patients to go untreated, or the threshold is inappropriately low. I mean, again, from the bowel point of view, but that's the feeling looking in.
Yeah, cochlear suspension before TVT came in was about 2,500 cases a year. So, and that was then only offered in specialist centres often.
Yeah.
So patients from Kent, where I work, had to go to London to have their surgery for the pretty 4 hours a consultant. So, 2,000 would be too less.
Yeah.
Too few.
So, as a patient, wouldn't you really want to go to a specialist centre? Wouldn't you feel that you were getting more security, a higher standard of care, a higher standard of surgery?
I'd want to go to a surgeon who was trained in the operation that he performed, regularly performed the operation, was under proper governance procedures, recorded his information on a registry, and had some idea of his outcomes as well. So wherever that surgeon were would be the place for me to find that care. The NHS is very poor at providing that information. So if I've got another problem, so I need a hernia repaired, in my hospital, I don't know who's good or bad. I've got no idea who's the good guy, who's the bad guy. I know who's the fast guy in theatre, but I don't know what happens 6 weeks, 6 months, 6 years later. And so as a surgeon, I can't find that information for myself and my family. What we're proposing for TVTs and mesh procedures is that we will have that information.
Mm.
The other thing is you may not, as a patient, want to travel from Kent all the way up to London for your surgery. But if you know that the decision for your surgery has been gone through in the specialist centre, you've got all of the advantage of all the experience, and yet your local surgeon has been doing them for 20 years. They're probably taught the person in the London centre anyway to do the operation. It's the crux of the decision making and the communication, rather than necessarily the surgeon.
Well, of course, it's a patient choice, and it depends very often what age you are, whether you're prepared to travel. It depends where your family are, whether they can. So there are a lot of other issues,
Absolutely.
I think, where you want to be treated. But can I just ask, from the point of view of the Pelvic Floor Society, there's the potential for an overlap between mesh insertion centres, which we've been talking about, and the rectal mesh insertion centres. Do you think it's right that they should be sited in the same place, or do you know how do you see this happening in the future?
At the moment, the centres for complex mesh problems are co-located with colorectal, urology, and that's, we think, entirely appropriate because the skill set and the different clinicians involved, taking out a TVT tape probably will not involve colorectal at all, whereas taking a mesh out of the vagina with involvement of the rectum definitely should involve a colorectal surgeon, but also someone who is experienced in dealing with mesh problems and the bowel. And so it makes total sense, we feel, I don't know what you would say, John, but to have all of the key players in the same centre. And I think it's going to happen anyway, because that's the way that the commissioning's coming through. It's coming from the women's health and gynaecology side. It's not coming from the bowel point of view.
Yeah, specialist commissioning is expected to commission specialist women's centres, so there will be co-location of urology, colorectal and gynaecology within the same centre.
And rather than reinvent the wheel, we will...
You couldn't practice without those three co-located specialties.
So
and imaging and pain.
Exactly.
So in the specialist centres, you might have people who are removing mesh, but you might have also people who are inserting mesh. Now that kind of worries the patient groups. It's something that they've brought up and talked to us about.
Well, we've seen that right from the start, actually, where some of the patient groups have lost faith in a surgeon because they're actually still putting in TVTs as well as removing them. I think it's a difficult circle to square, really. It shows that the surgeon has faith in the operations that they perform, whether they're inserting or removing them. For the patient, I can understand it's more difficult if they've had a very traumatic and difficult time with their mesh, and they are very vehemently against mesh insertions. But we have to be, hopefully as surgeons we're pragmatic to offer different surgical options for different problems.
Also, if you want, taking the mesh out can be some of the most challenging surgery, What you need is a surgeon who is really comfortable with the operation, with the techniques involved, and is confident and comfortable in putting them in, so you know exactly what the problems are when you want to take it out. What you don't want to do is go to a surgeon who just takes mesh out. I would argue the other way.
And do you have that now?
How?
Surgeons who just take it out?
I think there's a tendency in some of the mesh centres where they're so busy just taking it out and they're so vehement against mesh that it gets quite polarised. And therein lies potential problem, I think.
But from a patient's perspective, if surgeon A inserted mesh which caused that patient terrible pain, going back to surgeon A, presumably having had various interactions with him or her in the interim as well, which may or may not be satisfactory from the patient's point of view, going back to that surgeon A for the removal operation is quite difficult, emotional
possibly
process.
But that depends on the level of communication, counselling, information beforehand, and how he or she has dealt with the complication thereafter. I have had complications from the surgery that I have done, but to my knowledge, my patients come back to me. I then discuss whether they want to stay with me or whether they want to see somebody else, and I'm more than happy. I just want the best for them. And the vast majority stay with me because we've had an open dialogue throughout. It's difficult for the surgeon as well as the patient, for sure, in that one feels very responsible if there have been problems with an operation that you have done. And equally, you would do your damnedest to make them better afterwards. So it cuts both ways, I'd argue. And that comes down to what we were saying earlier about either probity or communication, and that's the underpinning line of all of this. And whatever sanctions we put in, whatever plans we put in, it won't change the fact that at the end of the day, an individual surgeon's practice is between him or her, the patient, the GMC, and the trust with whom they work. And there is no regulation above that.
Can I just ask you, you've been inserting mesh and all the rest of it for some years, I gather. So are there different types of materials that mesh? We have a general description, we call it mesh, and I think you called it tape at one time. And that's something that has really concerned patients. They didn't understand what tape was. They do understand what mesh is. And really what I'm asking you is, are there certain mesh materials that are better than others?
There were in the past. So I've inserted 2,648 TBTs since 1999, 12th of December 1999 when I inserted my first one. But all of those ones have been a specific type of mesh. So it's a macroporous, so it has big holes in it so that if you get a problem, the bugs can be eaten, the cells that scavenge and destroy inflammatory infections can be treated. And it was before then, yes, we had some horrible meshes. We had microporous, and there's been one used for prolapse, which was probably in the early 2000s, which was a dreadful mesh. It was a microporous one that the body rejected, and as a trainee I had experience of using bad meshes. But almost all of the TBT ones since the late 1990s are the type of mesh which has the least negative aspects to it. And when they introduced the TBT, they trialled 4 or 5 different meshes. It's in the original work from 1995, and they had problems with the other meshes, and that's why they came to the macroporous TBT type mesh. But even that's changed a little bit over the years. But it is still a mesh with big holes in it, which allows it to be incorporated into the tissue, not to move, and for organisms to be destroyed within its network.
That's different for the bowel side of things, in that we have the luxury of being able to use a collagen mesh as well as synthetic meshes, whereas, correct if I'm wrong, using collagen mesh for a TBT doesn't work and it just dissolves and gives way.
They do dissolve usually.
And so we know that polyester mesh is bad and is linked with a higher and unacceptable complication rate with mesh erosions and pain. And so we use polypropylene mesh or titanized mesh, so titanium coated or impregnated mesh. Again, and it's the polyester, well, the polypropylene mesh is the same mesh that is used in the urogynae and urology world. Collagen mesh, there are 3 types, usually porcine in origin. Our data at the moment, we can't say that porcine or collagen is any worse than synthetic, although there's a concern that recurrences may occur after 2 years or so. The advantage of the collagen mesh is it is resorbed by the body and replaced by the body's own scar tissue. So in 2 years' time there'll be no mesh left and only your body's tissue, usually, but that is unpredictable and very variable between patients. We can say there's no nice robust data with randomized trials, but there's a suggestion that the incidence of mesh-related problems are lower with a collagen mesh, but that is sort of anecdotal or case series data. We can say that the significance and the magnitude of the complications are lower with a collagen mesh, because the first thing that happens is the mesh dissolves and is eaten away by the infection, whereas with a plastic or synthetic mesh, it's there and it's there until you take it out. So we're in a slightly more favourable position in that most or many surgeons in this country would now use collagen meshes predominantly, myself included, because we feel that the risk profile is lower.
And the reoperative rates?
Reoperative rates, it would appear, the data such as we have it, is that it either works or it doesn't. We don't see a whole tranche of prolapses coming back after 18 months or 2 years when one would envisage the pig's all gone and then it all just falls apart. It either works and supports or it doesn't work, because the reason for failure is not necessarily that the mesh is dissolved. It may well have come undone, it may well have come off its fixation on the bone, or it may well have been that they managed to prolapse and continue straining such that it becomes lax below where you've done your repair previously. So it's not quite as binary as mesh failure or mesh success, really.
One of the things that's very clear is there is an evidence gap, but also one of the concerns that we've heard is that a lot of the reported outcomes don't necessarily match up with patient experience. So going forward, in order to sort of fill this gap that we seem to have, what outcome measures should we be using?
Specifically for the bowel-related, and again, this is where the HQIP data set is going to come into its own. Clearly, as a surgeon, we want to know the indication for surgery for bowel is either constipation and inability to empty or external rectal prolapse. So at the most basic level, we want to know the recurrence of prolapse at 2 years, 5 years, whatever metric we include. We want to know what the raw complication rates are, so mesh erosion rates, pain, fistulation rates. And then we want to know some of the more subtle things, which is it's all about quality of life, and so we then want to measure the bowel-related quality of life and see if we've done what we want to do. So our success rates, as far as we know, having reviewed all of the literature, you have a 65% chance of having significant improvement in your ability to empty the bowel if you have a ventral mesh rectopexy for that indication. You've probably got a 15% chance of it being no better and a 15% chance-ish of it being slightly worse. Those are as good as it gets at the moment. Whether or not we're ever going to get any more robust data, because it then comes down to how you're measuring quality of life, how you're measuring symptoms. What we will know is we'll have a better handle on the risk strategy and the risk complications, which is where I think the disparity of many of the patients who have been harmed by the surgery would say, well, actually, all of the published data say that a mesh erosion is 2%. I know lots of women here, and this surgeon's done that many operations, and the maths doesn't add up. Clearly, having the data recording, we will have better handle on those data. Which is where probably the urogynae and the urology specialties have got a much better head start on with your database than the
our data's from 2007,
exactly.
so we've got quite a lot of data on that. But it's obviously done by experienced surgeons who've used the database as well, so it might be slightly biased in that way.
And like us, you have a very clear understanding of the difference between a database and a registry, because that's very helpful.
I mean, we have a registry,
Yes.
they have a database. We need to build on our quality of data and our outcome data, but that's hopefully where this afternoon will come into.
It's quite difficult to try and work out what you should be collecting is the frank and honest answer, because there are various different fields there. So we want to look at success, and we want probably an overall patient assessment of whether they feel the operation has worked for them. Then when we start on questionnaires, then they become very lengthy and more difficult to complete. So if we have a sexual function questionnaire, that's a lengthy 10-page document, and then we add that to a bladder-specific questionnaire, and then we have to assess UTIs and pain. It suddenly becomes so unwieldy that nobody completes it. So there's a balancing act. We're meeting with one of the patient groups, I think, regarding what they think is acceptable data collection as well. So we're trying to involve the patient groups in that.
Yes, I mean, I think it's quite wait for our recommendations. I was going to give an opinion, but I didn't think I should. Right. Anything else?
Sort of obviously recording under the NICE guidance, they've stated all procedures have to be recorded. Do you as societies have a view on what would be the most effective mechanism for ensuring that happens?
We've sort of spoken before about this. Mandating is very difficult. It has to come from the trusts and within governance structures. We've looked at our data on the BSUG database recently. We have a 95% concordance with HES data, which is really good. So the latest data is certainly suggesting from centres that are involved in these difficulties that the data is all going on, or largely going on at the moment. But mandating it is the challenge, where NHS England purchases care doesn't mandate this type of activity often. I think we need to get around that.
So, I mean, you think you're capturing 95% of the operation?
When we compared in 2 or 3 centres, we compared our HES data to what was going on in the BSUG database, and yes, we got a 95% concordance.
Which, I mean, given you've got a voluntary database, that is very high.
Yep.
Are you satisfied with HES data?
I've published extensively on HES data, so I have to say yes, completely satisfied with that. The HES data is a good enough database to be robust and reproducible. So the HES data is. I threw my own stones at HES data before I started working with it, and there are ways it could be improved and better. And it has been improved and better, but it's generally considered good enough now for research to be done on it. And so it is considered as sufficiently accurate for research to be done. So it must be considered as being acceptable data. I have my reservations.
So working with getting it right the first time, the NCIR, I've recently just looked at my own data, which is their data is based on the HES data, and it's amazingly close.
Yeah.
I mean, it's
Amazingly what?
Close in the accurate in the what it's doing. Clearly, the weakness is it's down to the clinical coding. But having said that, it's not beyond the realms of possibility to say, right, these are the codes, and actually, as clinicians, we can tighten up what we're declaring as the codes.
But that does seem to have been a problem. I mean, accuracy around coding, especially around mesh removals, partial, full. And
well,
when we asked, to have some analysis of the data from a number of the self-accredited mesh centres, we did get comments back saying can't provide this because coding data is inaccurate and we actually don't know.
So the coding data, I was part of the NHS England group on coding data, and that was only altered 2 years ago, so that there are codes now for mesh removal. I think there was a prolapse mesh removal. So there weren't any codes before then. And they're due for another... It's going to be a catch-up on the mesh. If you think mesh removal is a sort of a relatively new science. So there weren't any codes for the 18 years.
And short of
before
a
that
time
last year.
machine, we won't get around that. We just have to move forward and make things more robust, so that in 5 years' time, you'll look at the data and you'll look at the codes and you say, well, yeah, that's 98% case accrual.
It needs updating again. It's not perfect, but there is data there now and there was none before.
Can I just go back? And obviously you said you've got a very high reporting rate. Pelvic Floor Society?
No, probably 40%, something like that, maybe more. This is one of the reasons I'm working with the coding side to see which codes are most likely to capture all of the cases that we're interested in. Because again, there isn't a code for a lap ventral mesh rectopexy. It could be coded in any way, any number of 6 different permutations. And so it's working out the subtleties of those to capture the majority of the cases. Then we'll go back and we'll see exactly how many cases are being done. Because quite sensibly, the first question I've been asked is, well, how many lap ventral mesh rectopexies are going on in the country? Nobody knows. Nobody knows.
But how long have they been going on for? And then the question is, how long does it take to identify the proper coding so that we can find out?
Well, exactly, which is what we're working on. It's what we're confusing here is we're confusing how the country works with what we really want to get to. Nirvana's over here, and we all know what it looks like, but this is how the NHS is.
So this particular procedure has been going on for how long?
For the last, 10 years, 8 years maybe?
And we don't know after 10
No.
years how many.
Absolutely.
I
But
think
then
for
you don't.
TBT, it was 2007 when the codes caught up to date with the clinical practice.
So a decade
Yeah, a decade. Oh, yeah,
on average.
just under. Yeah. So they're where we were in 2007 with no
exactly.
data.
It's not really a healthy way of going forward.
But it's the same for everything else in the NHS.
I get that. I'm just talking about new procedures, new
Yeah.
device, trying to assess accuracy about data.
That's
Welcome
why
to the NHS.
That's why we introduced our database all the way back from those
Exactly.
early years, so that we could try and get a handle on the risks and the complications and the negative outcomes. Because we were aware that there may be things that we weren't going to
But
capture.
should it be for societies to be taking that role as a voluntary assumption?
We were anxious that
no one else
nobody
is
else was
going
going to.
That's my point.
Yeah.
Thank you.
I mean, that's why, in a way, it's quite analogous to where the cardiac surgeons were 20 years ago, because none of this happened, and then a big thing about outcomes, and then the database comes in. And it's only when something happens that public demand then decrees that we have to do something about it. Luckily, each one of the 3 organisations has preempted this and started doing things in advance of, things.
But should we have to wait for a catastrophe?
Well, of course we shouldn't. I mean, it's a rhetorical question. It's obvious we shouldn't. But at the end of the day, who's going to pay for the infrastructure and the informatics to gain the data so that we can preempt this in everything? And where's the next catastrophe going to come from? So where should we put all the energy? And nobody knows.
Well, I think we could continue with HES for some time, because I remember it being introduced and it was really for administrative purposes. It really wasn't for clinical purposes. And therefore we need to sort of probably go on to something a bit more refined. Anyhow, final questions.
Final questions. We've been talking history. I'm a student of history, and I'm always interested in what's happened in the past as well as what happens in the future. Changing of attitudes. If we go back and look at some of the documentation, in fact, that you and indeed BALS have supplied to us, there was very clearly a concern expressed by clinicians when mesh appeared on the scene. And that concern was registered right at the beginning. It was certainly registered in meetings, documentation of meetings I've seen between your society and BALS, say, in 2004. Concern about it coming on too fast and we don't have the evidence base. I see it again in letters in 2010 written from the societies. So I'm sort of left wondering, at what point did clinicians have a change of heart? So although they had these concerns over a number of years, at some point the attitude changed. And I've not actually understood why that came about.
How do you mean attitude changed?
Attitude towards absorbing and taking on mesh as part of their clinical practice, rather than, we don't have the evidence here, there's inadequate evidence, we don't know the long-term outcomes. I've seen the documentation, it runs right through. And yet, at some point, clinicians do take this on with quite some force. And I'm not clear, I understand how that attitude changed or why.
The older operations were big operations with significant side effects and complications. So when you are given a newer operation that seems to be fairly a lot easier to perform and a lot safer, and then people start using it and they report, and then it does snowball of the positive aspects. So we see this in many cases medicine. There's a sharp swift lift when operations, and there's a static state, and then they fall down to a normal level when people understand the risks and complications. So I don't think the TVT operation was any different to any other procedure that has that exuberance to start with, and then a realism, and then
the documentation would sort of suggest there was this underlying concern throughout. And that's the thing that slightly worries me, and I'm sure would worry others, when we recognise these concerns still exist, that people don't feel they're comfortable, they haven't got enough evidence as to the effectiveness of these procedures, and yet, as you say, it rises.
So the leaders and challengers of our societies were uncomfortable with some of the things that went on. So you've seen those minutes which state that. And that was, how many of us felt at those stages. Then for TVT, for instance, a randomised controlled trial was published, I think it was about 2002, which showed good efficacy and limited side effects and complications within a small patient group. That's probably where the interest in TVT changed. And then it was expanded in an unregulated, uncontrolled way, which is, I think we're looking in hindsight, was wrong.
Can I just ask one question, final question? Should there be a mandatory register of interest for clinicians?
There's already mandatory registering of interest for clinicians within individual hospital trusts. So if I speak to a drug firm, I'm A, not allowed to, and I B, have to declare any interest. So whether that's done well within all trusts, I don't know, but it's already there, the process.
But it's not a national register. It's not. Why
it's held individually within hospitals.
And is it publicly accessible?
How about the GMC?
I think people have asked for that information, haven't they, from various hospital trusts, and been disappointed how unfull it was in some declarations. So a national mandatory register is tricky. Again, you think who would pay for it? Would it be useful? And those sort of things. I'm not necessarily sure. I'd have to have a reasoned, long, lengthy argument for justifying it and its costs and who was going to pay for it. But I wouldn't say no.
And did you agree?
I do. I think the trouble is all of this information is going to be there. It's how easy it is to get hold of and how public it is. Clearly, I don't think any of us, or the people who are working with industry in an appropriate way, none of us have any hesitation about declaring what we do, and that's fine. There isn't a general structure to declare interest in that sort of way. Clearly it's presented if one seeks to publish data and declaration of interest. It's given before lectures as a disclosure statement. So all of that stuff's out there. I agree, it's supposed to be on your individual hospital's database, but I'm fairly cynical about the robust nature of that, if I'm honest.
I mean, your professional regulator has a register of every doctor. Wouldn't be a massive leap to sit alongside that, a register of every doctor's interest.
As long as you're paying, we're up for it.
Is that your only objection? Is that it?
It isn't my only objection. It's quite complicated, the conflicts of interest. So I have to have a lecture on all of my slides, which says my conflict of interest. How far back do I go? Yeah. What sort of conflict of interest,
and what interest was it?
Was it a conflict in terms of this paper, or was it not a conflict? And I'm filling these out all the time, and I don't quite know if I'm doing it right or not, so I just declare everything from 1999.
Yeah, exactly.
And I don't think anyone else does.
Well, they gave me a pen and bought me a coffee. Does that
I can't even remember that pen, because we couldn't remember who bought us those pens in BSUG.
I think the interesting thing is how industry regulation has changed, and you're more likely to get things sharpened up through the industry side than reliant on the clinicians. Clinicians are usually too busy to worry about what they're given or what they've done. By and large, the majority are not
If
interested.
it works for parliamentarians, such as one we've got here, surely it can work for clinicians, can't it?
I mean, in theory, and none of us are against that.
I mean, you'll know in the States they had the Sunshine Payments Act, and pushing groups say to us, why don't we have that here?
I think we should draw this to a close because I could tell you a lot about the parliamentary system.